There we go. Hello, and thank you for joining today's virtual education program with Cancer Support Community Los Angeles. I'm Larissa Montalvo, and I am the program manager at CSCLA, and I welcome you to this week's webinar titled Fertility Preservation in Gynecologic Cancers. Fertility preservation in the young cancer survivor is recognized as a key survivorship issue, as the diagnosis and treatment of cancer have important implications for a woman's fertility potential and quality of life. This webinar will serve as a broad review of fertility-sparing surgical approaches, as well as established and emerging strategies for fertility preservation in women with gynecologic cancers. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. Now, before I introduce today's speakers, please note that we cannot see or hear you. Your video and microphone are automatically disabled for this webinar. We will not be monitoring the chat room, but you may enter your questions into the Q&A feature at any time. Questions will be answered at the end of the presentation. We may not be able to get to all of your questions today, but our presenters are invited to share their contact information at the end of the presentation. So without further ado, I would like to welcome today's speakers. Dr. Bradford Kolb is a board-certified reproductive endocrinologist and president of HRC Fertility. He specializes in the care of complex fertility problems and is internationally known for his expertise in reproductive matters. He is one of the largest providers of egg donation and surrogacy services in the United States, with patients traveling from around the world to HRC Fertility Pasadena to see him. Dr. Kolb is committed to reproductive rights for all intended parents and is actively engaged in improving access to care and affordability of fertility care. And joining Dr. Kolb today is Dr. Mihae Song, Assistant Professor, Division of Gynecologic Oncology at City of Hope in Duarte, California. Bilingual in English and Korean, Dr. Song is passionate about women's health and an expert in minimally invasive surgeries, as well as more complex abdominal procedures. She has provided free healthcare to pregnant women in Pakistan and trained future medical school students in surgical techniques. Welcome, Dr. Song and Dr. Kolb. Thank you so much for being here today.
Thank you very much. It's a pleasure to be here.
Thank you so much for this invitation.
The floor is all yours, Dr. Song.
Okay, I'm going to share my screen. All right. Are you able to see this? Okay. Hello, everybody. Again, my name is Mihae Song, a gynecologic oncologist from City of Hope, Department of Surgical Oncology. And I'm very excited to be here with you all to speak today on a topic that I feel strongly about. We really want to address fertility preservation in women with gynecologic cancers. So just as an introduction, worldwide, over 1.3 million women are diagnosed with a gynecologic malignancy each year, which includes ovarian cancer, uterine cancer, cervical cancer, and then as well as vulvar and vaginal cancer. 15% of these women are between 15 to 39 years of age, really in their reproductive age. And because of different screening methods, especially with pap smear, HPV vaccine, as well as advances in cancer treatment and different surgical techniques, about 80% of young cancer patients survive their disease. So we really want to shift our focus, not just on survival, but we really want to focus on survival and quality of life after cancer, especially for young women. So that really includes their preservation of fertility. So cancer and fertility. A lot of the cancer treatments that we may offer can affect the ability to become pregnant in the future, which is fertility. So women who have diagnosis of infertility or inability to become pregnant afterwards can experience very similar mental, emotional, and social effects similar to when they initially received the cancer diagnosis. So because of this, we think it's really important to address both the treatment, but also its impact on future fertility. And hopefully we could join, as a team together with the physician and the patient to really come together to have a treatment plan that works for everyone. So how does cancer therapy affect fertility? So fertility problems for women from cancer or its treatment comes in two main ways. So you could have either damage to the organs involved in reproduction, which is mainly the organs with the ovaries, fallopian tubes, uterus, and cervix. And the other way is to damage the organs involved in hormone production, such as the ovaries. And we all know that, women are born with all the eggs they will have, and the ovaries store those eggs. So when we have damage to these organs, it could really decrease, the number of, eggs in that ovary. And so some of these treatment options, including surgery, chemotherapy, radiation, can affect either, the organs themselves or the hormone production when they affect the ovaries. Chemotherapy can affect, blood supply as well as ovarian reserve, as well as radiation affecting the ovaries and the uterus. The amount of effect on fertility really depends on what age of diagnosis, the type of cancer treatment you're undergoing, the dose, especially with radiation and chemotherapy, and the duration of the treatment as well really affects for future fertility. Because I'm a gynecologic oncologist, I do, do the surgery, so today we really want to focus on surgery and some of the fertility preservations that we could offer, fertility-sparing surgeries that we could offer to patients. So here is a picture depicting the uterus, as well as the ovaries and the fallopian tube. And because of just, the gynecologic cancers involving these organs, standard treatment usually often include hysterectomy, which is a removal of the uterus and cervix, and bilateral salpingo-oophorectomy, which means just removal of both tubes and ovaries. And depending on what stage of cancer, whether it has spread or there's high risk, it may be followed by adjuvant therapy with chemotherapy or radiation. However, for women who are not done with childbearing and who want to preserve their future fertility, in selected early stage gynecologic cancers, we can offer fertility-sparing surgery to preserve some of these crucial organs like the ovaries, uterus, and cervix. So really, we want to offer hope to those young women and then to really partner up together to really address this important issue. So it's really important to discuss how cancer treatment can affect fertility and the different options for fertility preservations for all patients of reproductive age. And I know we focus on age younger to 30s, but women are delaying childbearing as well. So we really want to be inclusive of all patients of reproductive age and to really be there for the counseling. So some of the questions to ask your doctor initially, some of these questions that we kind of reviewed, but how will my cancer and the cancer treatment affect my fertility? And based on my treatment plan, what is my risk of infertility? What are the options for fertility preservations before I begin cancer treatment? And then can you also refer me to a fertility preservation specialist to discuss my options further? And where does this discussion fit? Oftentimes when a patient receives a diagnosis and receives treatment plan, sometimes they're, afraid to ask about future fertility, or they have other, worries. And sometimes it's kind of put in the back, but oftentimes women can have regret about not bringing this important issue up at the very beginning. It can be overwhelming just with a cancer diagnosis, and on top of that, to think about the future can be kind of overwhelming for a lot of patients. So, but we really want to encourage you to really fit this discussion right, before we start with any treatment. We reviewed how surgery, chemotherapy, and radiation can really affect future therapies. So, this is kind of the, the algorithm that we can't go through. When you discuss the impact of your treatment, are you interested? We always have a discussion with, the young women saying, are you interested in preserving fertility? And that really determines the next steps, whether to proceed with treatment if you're not interested, versus, really referring them quickly to see a reproductive specialist to discuss different options. And really, it's a really multidisciplinary team approach where we have, doctors and providers from different fields and specialties with the patient coming together to have a really a discussion and to go forward with this. So, I really want to focus on 3 gynecologic cancers that young women experience, and to kind of go into specifics. And then, so we'll address this. So cervical cancer is the most common gynecologic malignancy in young women. Up to 40% of cervical cancer patients are under the age of 45 years. And standard treatment for early stage cervical cancer include hysterectomy, which is the removal of the uterus. However, for young women, fertility-sparing surgery options do include just the removal of the cervix itself and leaving the uterus and ovaries intact. Some of these procedures are called conization, or simple or radical trachelectomy. And here in the picture, you could see how we can just remove the cervix itself and leave the stitch behind to have the uterus intact, and the ovaries will be intact as well. And there's been studies that looked at oncology outcomes long-term, and it's very similar to the standard treatment of hysterectomy. For advanced cervical cancer, surgery may not be an option. So, usually we do offer and recommend chemotherapy and radiation for advanced cervical cancer. So for young women, radiation can really affect the ovaries and kind of induce early menopause, so we try to work with patients before we start radiation. This is a surgery that we offer, which is called ovarian transposition. And the idea is to really move the ovaries away from the radiation field to minimize exposure and damage. And pregnancy rates after this procedure are approximately 50 to 75%. And it can also prevent premature menopause and preserve fertility. There are some complications involved with it, including fallopian tube infarction, chronic ovarian pain, cyst formation, and sometimes even though we, move the ovaries away, it can go back to the original position, and radiation can affect it as well. So moving on to ovarian cancer. Ovarian cancer is the most commonly diagnosed cancer in young women, and about 3 to 17% of ovarian cancer patients are less than 40 years of age. Standard surgical staging includes hysterectomy and removal of both tubes and ovaries, and most of the time can be followed by adjuvant chemotherapy, depending on final stage and histology. However, there are options for fertility-sparing surgery, especially if it only involves one ovary and there's no, spread. So we would remove that affected ovary and tubes and really leave the normal-looking contralateral side and the uterus intact. If it looks normal, we don't recommend biopsy of the normal-looking ovary because we don't want to affect future fertility. Ovarian cancer, there are a lot of different histologies or different types of ovarian cancer that can affect different age groups, and some of these affect more of the younger patients. However, so there can be candidates for fertility-sparing treatment. Some of these histologies include germ cell tumors, sex-core stromal tumors, borderline tumors, and really early-stage invasive epithelial ovarian cancers. Endometrial cancer is the most common gynecologic cancer in women in the US, and about 7% of endometrial cancer patients are under the age of 45. Standard treatment involves surgery, and especially in low-risk disease, there's very high cure rates of, up to like 93% or even more. And it can be followed by chemotherapy and radiation, again, depending on stage and the histology. So when it's really involving the endometrium of the uterus, patients say, how can we undergo fertility-sparing options? And so for cancers that did not spread into the muscle myometrium of the uterus, We can include hysteroscopic resection, which is kind of like minimally invasive, just resecting the portion of the endometrium involved with cancer in combination with hormonal therapy with progestin. And there's two different types of progestin therapy that can be offered. One is orally, which is taken daily, or delivered with an intrauterine device, IUD, that contains progestin, or a combination of both. 50 to 84% of women can go into complete remission, but it can recur up to 50% of the time. So it's really important to follow up with, endometrial sampling every 3 months until remission. And then we definitely recommend patients who wish to, pursue fertility to go on at that time. So some of the questions that I get after, the treatment is, how safe is this fertility sparing option? What is the recurrence risk? Is it as good as standard treatment? And, what are the chances of, me getting pregnant after the treatment? And these are very important questions to address. And so I wanted to kind of review this paper or study that really looked at 153 studies that was published, including more than 12,000 patients who underwent fertility sparing surgery for cervical cancer, ovarian, and endometrial cancer. So, it is a lot of numbers, but just to point out, is it safe oncologically? What's the risk of recurrence? And if, the red box shows, most of it is favorable. It's very, low, especially in cervical cancer, and ovarian, because there's other ovary, there may be a recurrence risk. And then endometrial cancer, there is a higher, recurrence risk. But we have to just kind of compare it to patients who undergo standard, and this is almost comparable, especially in cervical cancer. So that's why we can offer these to young women. The other question I get is, pregnancy rate. After I do this fertility sparing option, am I able to get pregnant? And then so looking at studies, it is favorable, up to even 70% of patients in ovarian cancer and endometrial cancer can become pregnant if they wish to. It is interesting to note, even though patients may choose fertility sparing surgery, about 50% actually undergo pregnancy or attempt it. So, pregnancy in women treated for gynecologic cancer may require specialized surveillance, especially just monitoring the baby as well. And then, however, because we want to watch for any high risk of preterm delivery, premature rupture of the membrane. So with the obstetrician, we definitely make sure that there's close monitoring. But it's relatively favorable for reproductive outcomes after this kind of surgery. So in conclusion, it's oncologically safe. It's high efficacy of fertility sparing surgery, and women with subfertility may need to undergo assisted reproductive treatments to achieve pregnancy. And this is where we would refer patients early on, hopefully before treatment, to discuss these options with Dr. Kolb. So these are some of the patient resources that could be found online, and they have great information on there for you to check out. And then, so I really love this, picture. This is an actual gate at City of Hope campus. We really affirm the vision that health is a human right. So in that spirit of that, cause, one of the early leaders coined this phrase, which became kind of like our mantra. There's no profit in curing the body if in the process we destroy the soul. So, I really truly believe in treating the entire person, body and soul, and, with that as fertility preservation in women, and especially as survivors of cancer. I just want to really thank you for this opportunity. And if you have any questions, please email. Don't hesitate to email or call our office. Thank you.
All right, this is Dr. Kolb. Just give me one moment here. My slides are a little slow to load, but they'll be on in just a minute. Dr. Song, thank you very much. That was very informative. And a few key takeaways for me in listening to your talk is, first of all, the sense of partnership. And that's really critical. The partnership that, we're forming with CSLA, with the City of Hope, bringing together the fertility specialists with the oncologists and the support systems out there for patients. I've been very blessed to be working with the City of Hope for over 20 years. And I've seen dramatic changes on all sides of the medical community in regards to fertility preservation in cancer patients. So it's been a wonderful journey to be on. I actually was planning on being a gynecologic cancer specialist, but life took me in a different direction. So the intersection of fertility and cancer is very near and dear to my heart. So let me just go through some basics here. As Dr. Song had alluded to, there are a lot of great things happening with oncology. Diagnoses are being made much earlier. There's much better treatment modalities that exist now than previously existed. Targeted therapies, ability to minimize complications associated with chemotherapy, radiation therapy. Future is going to hold things like genetic modulation, immunotherapies as well. So a lot of exciting advances going on. And we see a significant improvement in patient survival, but also long-term quality of care, which is really the most important thing for patients. Our goal, everybody's goal, is for you to live as long and happy of a life as possible. The fertility preservation is an interesting intersection with cancer therapies. First of all, I want to really stress, we have a partnership with your oncologist, like me as a fertility doctor. I do want to say there's lots of great fertility centers and doctors out there. So make sure you're choosing to work with somebody that you feel a strong partnership with, and that you feel is partnering with your oncologist as well. But I always stress to all patients, the most important thing is that you survive your cancer, and you do it in such a way that you can live a long and happy life. So that's our basic focus here. And our treatments extend not just, fertility preservation for cancer, but there's other benign causes or diseases that can adversely affect your fertility as well. So we want to minimize the loss of fertility for all patients. I'm going to talk very briefly about fertility preservation's options for men. Men have it a little bit easier because I simply need a sperm sample. While it may not be always easy to get that sperm sample from some men, especially undergoing cancer therapy, it's generally an easier process. And that, like I said, that's not to minimize the process for them. But the toxicity of chemotherapy, radiation therapy, and things like that is related to how these interact with spermatogenesis, the production of sperm. Sperm production is a little bit different than egg production. Sperm production, men make new sperm for the most part every day of their lives. They're continually turning over the supply. So sometimes cancer therapies can have a very adverse effect on the production of sperm, and men may actually become azoospermic or lack the production of sperm for a year after their therapy, and then there is some rebound in therapy after they undergo their treatments. Things like chemotherapy tend to be more sparing of the sperm production. Radiation therapy tends to have a more permanent effect on the sperm. It's also related to the age of treatment. Younger patients tend to rebound a little bit better than patients a little bit later in life. And it's just because of the basic physiology of sperm production. Some men do, due to surgical therapies that may interrupt nerve or blood flow to the, or innervation or blood flow to the testicles may, reproductive tract may affect erectile dysfunction, but that should not be something that interferes with their ability to have children in the future. Ideally for our patients, we want to freeze sperm samples before you begin therapy. If you're hospitalized and you can't come in, if we can get a sperm sample brought to the clinic or to a sperm bank, that suffices just fine. For men that are unable to produce an ejaculate, there is an ability for us to surgically extract the sperm. It's a very simple outpatient procedure. If you're in the hospital, we might be able to coordinate with a urologist to do that and have the sample delivered to our office or to a sperm bank for freezing. But also, look, I do want to stress, if you're not able to save your sperm or it's too late in your therapy, there's other ways to have children. Donor sperm is an option that's always open to patients. And for all patients, there's lots of ways to have a family. You know, we want you to be healthy when you have your family. Things like adoption are great options for individuals as well. Fertility preservation for women is a little bit more complex, and that's what Dr. Song was alluding to in her talk. This is a very important slide here. The green line here that goes down as you go to the right is the natural loss of fertility. And cancer therapies can dramatically shift this curve such that there's a rapid loss of fertility. So ideally, we want to freeze eggs or embryos as early in this process as possible for you to maximize your chance of having a successful conception. The blue line that's pretty flat going across the top is patients that use egg donors to conceive. So, you know, the important thing of that, there's two important points. One is if you've lost your egg function, your ability to conceive with your own eggs, egg donation is a wonderful option for many patients. But also the importance of that line is if you're 35 and I freeze your eggs in at your age, you could come back when you're 45 or 50. And the nice thing is the chance of getting pregnant would be as if you were 35. So the loss of fertility for women is largely compromised to the egg quality. There are tests that we do to look at your ability to conceive or the quality of your eggs. And these are simple blood tests. These may be able to be done in the hospital if you're hospitalized, but could be done at most doctors' offices. FSH and AMH, anti-Mullerian hormone levels, are great predictors of your fertility. Ultrasounds that look at the ovaries, we can count up the number of eggs that we see as a really great predictor as well. So these are things that we want to do before considering delaying your therapy for your cancer treatment. We want to be realistic, and if there's a chance that we can retrieve healthy eggs and freeze them, great, but we want to do our due diligence in advance before we delay anything. Now, the effects, Dr. Song had related to, or had discussed this, radiation therapy on the female reproductive tract. Radiation therapy and chemotherapy, they act very differently. And if you're having pelvic radiation for like a cervical cancer, this can adversely affect the uterus. Even if you keep the uterus and there's no surgery, it can make the uterus such that the vascular supply to the uterus is compromised, and it may prevent you from being able to carry a pregnancy in the future. But if that's the case, there's always surrogacy as an option. And that's a whole different discussion as far as how that works. But there, once again, I mean, you can potentially use your eggs and still have a healthy baby, but it may be someone else carrying the pregnancy for you. Where Dr. Song had talked about moving the ovaries up out of the pelvis, the goal of that is to prevent the effect of radiation from compromising the egg quality. If we're able to retrieve and freeze your eggs before radiation therapy, that's another great option that you have open to you. So this is just discussing some of the things that Dr. Song had alluded to. Sometimes patients will use certain types of anti-hormones for chemotherapy to protect the ovaries, but that doesn't work for radiation therapy. So if you're reading about that, things like Lupron may help with preserving egg quality, but in regards to chemotherapy, but not with radiation therapy. The toxicity or the harm of chemotherapy on the ovary is, there's so many factors that go into this. It depends on the type of chemotherapy that's being used. Some chemotherapies are actually very sparing of sperm and eggs. Others are very toxic. It also depends on the total dose of chemotherapy you receive. It depends on the concentration. So there's many variables here that it's hard to predict the overall impact that chemotherapy is going to have on your future fertility. And that's in regards to eggs that are still in your body. It also depends on your age and your baseline fertility. So women in their 40s already have compromised fertility. So it's going to have a much more profound effect than it would be for somebody perhaps in their 20s or even their teenage years. If we do move forward, if we do have the opportunity to work with you and your oncologist, ideally we would like to freeze your eggs before there's any chemotherapy. This slide here just relates to some of those anti-hormone or therapies that can be used to help minimize the toxicity of chemotherapy on the eggs. That should be discussed with your oncologist to see if that's an option for you. So ideally, for couples in significant relationships with a male partner, we'd like, if you're going to freeze embryos, or if you're freezing eggs, we'd like to do that before treatment, ideally. But we know some therapies, we can't wait. It's going to compromise your health. And I have a slide that refers to this in a moment, but I need a few weeks to work with you to get the eggs to a point where I can take them out and freeze them. If that's going to compromise your survivability or your quality of life, I would advise you not to choose this option. And there's just a whole bunch of different things here. Rather than going into them, know that often you do have options before, during, or after treatment. And those are things that we should discuss, one-on-one with you as a patient, and also with you, with your oncologist, working together as a team to figure out how do we best preserve your fertility and improve your ability to survive your cancer and with a very healthy life. One of the things that we do to help look at the quality of the eggs is we do ultrasounds to look at the ovaries. On the picture there, those are three ultrasound pictures. The one on the top left where it says ovary there, you see one little dark circle there. That's called a follicle. It's where the eggs are. For patients that have very few follicles like that, their fertility is already compromised. So fertility preservation through egg freezing may not be an option. The bottom slide here, though, you see lots of follicles there. So that might actually be a great option for that patient to freeze their eggs in the future. What is in vitro fertilization? Well, I should actually break this down a little bit. We have egg freezing and in vitro fertilization. Both of those involve a process of giving you fertility hormones to stimulate the eggs to grow and to mature. The reason we do that is we can really only work with mature eggs. Sometimes we will retrieve immature eggs, but the science for that's very, very rudimentary, and it's not a great option for most patients. Like I said, you're on those fertility medications for up to 2 weeks. And we have a great partnership with the Live Strong Foundation that will help supply the fertility drugs. Insurance is really pretty protective of benefits for patients with cancer who are looking at fertility preservation in the state of California. So we should look at those insurance benefits to see if you can access those benefits to help defer the cost of this process. Now, with egg freezing, we freeze simply the eggs unfertilized. If you are in a significant relationship or married, we can look at fertilizing those eggs, creating embryos, and freezing embryos. So they're great options. There's pros and cons to each of those. So we want to look at that very carefully. Hold on one second. There we go. Now, ovarian stimulation, that's the process of taking the fertility medications. The two pictures vertically on the left is showing immature follicles there. That's before the stimulation occurs. And then the way we know the eggs are maturing and doing well is those follicles grow very large. And that's what you see on the right. So from that, we can tell that picture there on the right, once those follicles get to a certain size, it tells me the eggs are ready to come out. Now, those big black circles are not the actual eggs. The eggs are microscopic. So they're not quite that large. The egg retrieval process is really pretty straightforward. It's done under an IV anesthesia. We have an anesthesiologist here to make sure that you're comfortable and safe through this process. We use a vaginal ultrasound and a small needle to take the eggs out. So the needle goes through the vagina into the ovary to take the eggs out. You're asleep when we do this process or the egg retrieval. You're not going to feel any pain with the egg retrieval, but you're going to be uncomfortable for several days after. So you'll need to plan on resting for a few days. Now, with the City of Hope in particular, they treat a lot of adolescents for cancer such as leukemias. And I'm very, very cautious. I don't want to do anything that's invasive or uncomfortable for our patients. So with our younger patients or our virginal patients, we never do a vaginal exam. We never do a vaginal ultrasound. We can do this process with the ultrasound up on top of your tummy, safely monitor the growth of the eggs, as well as the egg retrieval process. So I just want to stress that for our adolescents and virginal patients, this does not have to be something that feels intrusive or invasive in that regard. For egg cryopreservation, this is kind of a more general slide here, but it's a numbers game. And we always want more eggs to freeze. Ideally, I'd like about 20 eggs to freeze. Some patients might get that in one egg retrieval cycle. Some may need 2 or 3 cycles. That may not be an option if you're undergoing cancer therapy. But the reason why we want so many eggs is not all the eggs will fertilize or grow. Some are abnormal and we can't use. And even when I have a healthy embryo, it's not a guarantee of a pregnancy. So from the egg freezing side of things, and also the embryo freezing side of things, we always want a good number of eggs or embryos, but we have to work very carefully within the context of the cancer therapy that our patients are going through. And like I said, we don't want to do anything that's going to interfere with that process. This slide here is showing the development of an embryo. So if you go from the top left, go across, down, and back over to the left there, it's just showing the progression of an embryo. The embryo starts as one cell and eventually grows to hundreds of cells. This is important for several reasons because it gives us an idea about the overall quality of the embryo. But there, we have patients that have genetic issues that may be predisposing their offspring for cancers, or have other, when we screen our embryos, we can screen for things like Down syndrome and other processes. By allowing the embryo to grow to this extent, we're able to genetically screen the embryos, so we get a better sense of the overall quality of the of that embryo, the genetic normality. And for patients with certain types of cancers, we may be able to identify embryos that are at risk for transferring the cancer risk to your offspring. So you would have an option whether or not you wanted to use those embryos in the future. Ovarian tissue cryopreservation. This is probably a best option for patients that don't have the time, those 2 weeks, to undergo an egg stimulation and egg retrieval. And basically what we do is we take a little bit of ovarian tissue, so there is a surgery involved. We would ideally work with Dr. Song or somebody else to give us some of the ovarian tissue to work with, and we freeze that tissue. I got to say, this is somewhat experimental. There's different ways of extracting those eggs from the tissue. Sometimes that tissue is transplanted back into the body. And I know there's a lot of research going on to see if we can retrieve the eggs from that tissue, create the embryos in the laboratory, and then transfer the embryos back to the uterus. But it's somewhat experimental. The last time I checked, there were less than 500 births that have come from this type of cryopreservation or freezing of the ovarian tissue. So this is something I look at more as kind of a one of the last options that we would recommend patients choosing. This is simply looking at some of the hereditary cancers that we can test for. The second one there, the BRCA, is very common in breast cancer. But if you have a cancer that's caused by a single gene, we will have the ability to test the embryos in the future to minimize passing that risk to the offspring. And that's through a procedure called Preimplantation genetic testing. And that's what I was talking about a little bit earlier. We're able to take a few of the cells from each embryo, test them for things like Down syndrome and single gene diseases, so that you as a patient can better choose which embryos you want to transfer. I love that, Dr. Song had a very similar slide here, but I'm going to reiterate some of these points. Will my treatment affect my ability to have children? And it's a very good discussion to have both with your oncologist as well as your fertility specialist. But as I mentioned earlier, there's lots of ways to have children. Sometimes it's not exactly what we want to choose, such as using our own eggs or sperm. That for those that are open to alternative options, things like egg donation, sperm donation, surrogacy, adoption are great options for their patients as well, or for patients to have children. And then also exploring with your oncologist and fertility doctors, what steps can you do to preserve your fertility? So Dr. Song did a great job talking about like moving the ovaries out of the field of radiation therapy, sparing the uterus with cancer surgery and treatments. So there are options that may be appropriate to you, but you want to explore those very carefully to see if it compromises your ability to survive your cancer, or does that therapy really preserve your fertility? And then also, how long after treatment can I get pregnant? For a lot of our breast cancer patients, the oncologist will want you to be off of or be technically cancer-free for anywhere from 2 to 5 years. So that's a discussion to have with your oncologist. But keep in mind, I mean, once I have your eggs or embryos frozen, you can come back and use them anytime in the future. They don't go bad. And then also, I think, one of the things most critical for me is, will harvesting or removing my eggs, will that process compromise my fertility treatments? The last thing I want to do is to compromise anybody's survival or quality of life. For those that are having surgery on the uterus or the cervix or radiation therapy, you want to, at some point, we're going to have to address, can you carry that pregnancy, or do you need to use a surrogate? And then also something's a little bit out of my field, but will your cancer therapy put you into a menopause, an early menopause? And if there is a risk of that, that's something that's going to be dealt with after your therapy. But there are great doctors to work through those issues with you. So, strategies to minimize cancer treatment costs, as I mentioned, thorough review of insurance benefits. There was a great bill through Senator Anthony Portantino that went through about 2-3 years ago that helped ensure some insurance coverage for California patients to have their fertility preservation treatment paid for. The Live Strong Foundation I've worked with, probably close to 20 years or since its inception. The fertility medications can be very expensive. Those bills can easily exceed $4,000 for the fertility drugs to stimulate the eggs to grow to maturity. Through a partnership with Merck Pharmaceuticals, Livestrong is able to provide those medications to many patients at no charge. And then look, always explore with your fertility center doctor. We know that this is a stressful time in life. We know that many people are going to have to leave their jobs and employment. We know it's financially stressful. So we will always work with you to minimize your cost as much as we can. And I'm sure many doctors and centers will as well. As far as, you survived your cancer, we froze your eggs or sperm or whatever, or, we did this while you were undergoing treatment. Is my child going to be compromised? Is my child at an increased risk for having this cancer or other problems? And fortunately, there's a great deal of data to show it doesn't increase your child's risk for having cancer or medical problems in the future. Now, a caveat to that is if you have a genetic issue that caused your cancer, if your child gets that gene, they'll be at an increased risk. But the cancer itself, the therapies that you're receiving do not increase health risk problems to your child. So you can move forward if you choose to do this, knowing that you're not doing anything to compromise your child's life or quality of life, I should say. Just a few of my insights. Fertility preservation is best if we can do it before you start chemotherapy, but only if it's not going to compromise your treatment success for your cancer. The stress of cancer sometimes can affect the quality of eggs and sperm. So we want to try to do this as early in the treatment process as possible. But we also want to make sure that you have a good support system there to help you through this entire process. And as I mentioned, we should not be delaying your therapy if it causes any compromise to your health or well-being. It's something that should be explored early with your therapies as possible. So this is my contact information. Actually, I just noticed the address is incorrect. We moved, but we're still in Pasadena. The first number there is my office number. Look, this is a really tough time for patients. I give you both my cell phone number and my email. I ask that you don't just cold call me on my cell phone because I'm not going to pick up. We live in a world of spam and all these junk calls that we get. Feel free to text me. I don't care if it's 10 or 11 o'clock at night. If I'm asleep, I'll get it first thing in the morning. But this is something, my promise to you is I will get you in ideally within 24 hours of that text or our interaction. So we can look at this a little bit further and see how we can best help you. It's just really critical that we do this in a time-sensitive fashion that minimize any delay in your therapy for your cancer. And I'll be working with your oncologist, whether it be Dr. Song or somebody else, just to make sure that we're all on board looking after your health and well-being. So I appreciate your time. Thank you very much for being here with us, and I look forward to any questions you may have.
Thank you so much, Dr. Kolb. I'll welcome back Dr. Song here as well. If you don't mind stopping your screen share so we can all see you for the Q&A. Thank you. For those of you who are here with us today, I have placed Dr. Song and Dr. Kolb's contact information in the chat. I have also provided links to City of Hope's fertility risk related to cancer treatment guide. There is one in English and one in Spanish. So those are all in the chat. Dr. Kolb, are you having some difficulties with the screen?
There we go. All right. I had to find the right spot for it. I'm sorry.
No worries.
I'm not as tech savvy as some of the younger patients and people here.
I saw you smiling. It made me chuckle. Okay. All right. So we have a couple of questions here for the two of you today. The first question that came in are, what are options for those who have both PCOS and a gynecologic cancer diagnosis?
So let me start with that, if that's okay. PCOS is polycystic ovary syndrome. It is a gynecologic and endocrine disorder that it can make it more difficult to conceive on your own, but it's a very common thing that we deal with, especially in the fertility world. So that should not adversely affect our ability to treat you or to retrieve eggs. So it's just, it's something that we take into consideration with your cancer therapies, but it does not alter, from my perspective, anything I'm going to do or your timelines.
Just to echo that, as soon as we work with your treatment plan, we definitely would refer you to see Dr. Kolb or other specialists to discuss those options, but we work together.
Wonderful, thank you. Okay, our next question. If you're unsure about your desire to start a family, do you still recommend freezing? And what is the cost to bank per year?
You have to, it's a really personal question. If you are uncertain, it's certainly something you should consider, because you don't want to wait till after therapy and a few years down the line. If you didn't freeze or look at that option, it may be too late as far as with your own eggs or sperm. So it's something that you should look at. And then as far as like the cost of storage of tissues, that's typically at most fertility centers going to run in the $500 to $1,000 range annually. But it's something that, once again, as I said, you can talk to your fertility specialist. Considering what you're going through, they may be able to waive some of those costs or discount them for you.
Thank you, Dr. Kolb. Okay. Next question. Someone's asking, if you received a Lupron injection during cancer treatment, is there a better success rate of getting pregnant naturally?
Well, Lupron, what Lupron does, I'm gonna take it from the fertility standpoint. Lupron just it quiets down the development of eggs, so it kind of turns off hormonally what's going on in the ovary. The Lupron is a temporary drug. It will come out of your system in time. I'm talking about months in general. So it's not something, the Lupron itself is not going to compromise your ability to have children in the future. It is a little controversial whether or not it helps protect the ovaries from chemotherapy. Dr. Song, do you want to speak to that a little bit?
So we usually give, Lupron for young women undergoing treatment for like leukemia or lymphoma, and they ask us, is there any way to prevent or better success? And like Dr. Kolb said, it is a little bit controversial because there's different studies showing benefit and some studies saying none. But as long as there's no contraindications to it, we do offer it, so that there may be some chance, but again, it's not like a hard, evidence saying, yes, give it to all patients. So it's really, a discussion, talking about the benefits and the risk of, receiving Lupron during cancer treatment.
So mixed results overall, it sounds like. Thank you. Okay, someone's asking if 43 years old is still an okay time for fertility treatment.
It's getting a little bit challenging for women in their 40s. And I always hate saying this. It's the age of the eggs matter. And so, when we talk to our patients in their late 30s and 40s, I never mean to make anybody feel old in a sense, but it's an egg issue. As Dr. Song related earlier in her talk, you're born with all the eggs you'll ever have. So at 43, your eggs are 43 years old. It's a challenging time for patients. We would just have to see, is it possible that we can help you create a baby or embryos at your age? We would do this regardless if you're 43, 33, or even in your 20s.
All right, thank you for that answer, Dr. Kolb. Okay, this is the question I had as well, so I'm glad somebody is asking this, but is there any advice that either you would give on how to find egg donors or where to find them, or even where to find fertility clinics on that end if someone's looking for that?
Maybe, I guess I'll start since I'm the fertility doctor. Look, there's lots of great clinics and doctors out there. If you live in some place like the Los Angeles basin, I mean, there's lots of us out here. So, some considerations might be, proximity to the center. You may want to get recommendations from your oncologist. Are there people that they work with and like working with? I would generally recommend going to a well-established center if you're freezing eggs or if you're doing this during your cancer therapy, because there's some nuances that very not well-established clinics may be able to provide. So I generally would say well-established clinics that have good relationship with your oncologist or maybe your gynecologist. But there's certainly lots of resources out there for you. There is also something called SART, SART.org. If you just want to simply get online and compare fertility pregnancy rates from one clinic to another, keep in mind, it's not always apples to apples that you're comparing. It'll give you a sense of the success and the types of numbers of patients that a fertility center is actively engaged with.
Okay, and to that end, do fertility clinics typically help you find egg donors?
Oh, I'm sorry. I got off on a tangent there. Yeah,
so, it was a two-part question.
Yeah. So look, there's two major sources of egg donors. One is you may bring in your own egg donor. You may have a younger sister, a friend, niece, whatever. Or we can refer you to an egg donor agency. There's lots of them out there. Most from the egg donor agencies, most of the time you're not going to meet the egg donor and you can request it, but you're looking at pictures, medical histories, family histories. There's a lot that goes into, you're provided with. I almost liken it a little bit to internet dating. I've been married for 30 years. I've never internet dated, but I imagine it's what it would be like. But no matter where your egg donor is coming from, there's a couple things. We're going to always evaluate them to make sure they're a good genetic match with your partner, sperm donor, whatever the situation is. Also that their egg quality is good and that overall they're healthy. And then legal contracts are always set up to protect your rights as the parent in the future.
Wonderful. That's glad to hear that that legal protection is provided as well. Okay. We have a couple more questions we have time here for. Our next question is, if someone had an ovary removed, since they had tumor in that ovary, is there a diminished chance of pregnancy?
I'll let Dr. Song address like the surgical aspects of it. But I think it really depends on why the ovary was removed. If it was for a condition like an inflammatory condition like endometriosis, the other ovary may be compromised. There's a number of things that would go into it, but the ovaries are somewhat independent of each other, I would say, as far as like, why you may have had it removed surgically.
Yeah, I definitely agree. I think it depends on the reasons for getting it. Usually, if it was for a large cyst or benign tumor, it can occur with an ovary. So we definitely let them know that you have one ovary, and you really want to protect the ovary. So to seeing a fertility specialist early on will definitely help kind of give you all the options, because the cyst can occur in the other ovary, and then we may have to remove that ovary as well, right? So and then that'll be too late to do any kind of I think procedures at that point if there was like a large mass there. So I think it really depends on the reason why. But people do spontaneously get pregnant afterwards with just one ovary because it is independent. So you still get your period, ovulate, and can spontaneously get pregnant.
Great, thank you. It's such a wonderful opportunity to have such two different perspectives here with you today. So I'm so happy for that. Okay, we have two more questions. Our next question is primarily for you, Dr. Kolb, and I'm sure that this answer varies, but I think they're asking for the average cost of egg harvesting per harvest procedure and how many procedures are usually necessary to get the desired number of eggs.
Yeah, both of those are really can be really quite variable answers. The cost in general, you're looking at, I would say probably, if this is for a cancer and you qualify for something like the Live Strong Foundation, where they're providing the fertility medications, you're looking at probably somewhere in the, I'm trying to think through different centers and things, probably in the $7,000 to $10,000 range. And there's different things, costs that or services that may including storage for a period of time. If you have to pay for the fertility medications, that may add up to $4,000 worth of cost to the treatment. And then as far as the, like I said earlier in the talk, we really want to explore your insurance benefits because there's a lot of benefits that people don't know about. And they're not like clearly stated if you go through your online portals to look at your benefits from your insurance company. As far as the number of eggs, I would say just kind of general, more is better. But for most patients, if we can get about 20 mature eggs, we're feeling really comfortable we have enough there to have at least one child. So the last component, because I don't want to forget anything this time, the number of cycles or egg retrievals that's going to take, it's really independent. Sometimes we have patients that do that easily in one cycle. Others may take 2 or 3 cycles. And that we will only know once we can do an ultrasound, look at your ovaries, see how many follicles that are there, and do a little bit more of an assessment.
Great. Thank you, Dr. Kolb. Okay, and this is our last question. A participant is asking if tamoxifen, if someone's been taking this hormonal therapy medication, during their reproductive years, is it going to affect their chances of getting pregnant in the future?
So I can answer that for a little bit. And then so tamoxifen, usually, people may take it for 5 to 10 years after a breast cancer, therapy. And depending on what age you start, again, age definitely matters to success of pregnancy. So a lot of women may choose to harvest their eggs before starting on, hormone therapy. And that's the discussion that you could have. Tamoxifen itself can cause some changes inside the uterus. So, it can cause abnormal bleeding, very rarely another cancer inside the uterus. So that's, very carefully monitored during the treatment. And that may affect, pregnancy if that does occur.
If I could just chime in, Dr. Sung, I'm really glad you talked about like the length of time that you're on a tamoxifen. From my perspective, I don't see tamoxifen harming your eggs in general. I don't think it's going to compromise your fertility in general, but it's the delay. Like if I have somebody in their mid-30s taking tamoxifen for 5 or 10 years, well, now they're in their 40s when their egg quality is compromised simply because of their age, not because of the tamoxifen. So this is something that some patients may want to consider working with their oncologist and a fertility doctor to harvest some eggs And actually, I leave my patients on tamoxifen when we do the egg stimulation. So it's something that can be done safely. We get your eggs frozen when you're a little bit younger.
That's great. That time component, yeah. All right. Well, thank you both so much for your time today. That's all the questions that we have. We are so grateful to have hosted both of you. Thank you for taking the time to be here. And for those of you who are still with us, this will be recorded and be up on our virtual library in just a couple of weeks. And again, the contact information is in the chat. So feel free to reach out if you have any questions.
Thank you.
Thank you very much. It was an honor to be here.